This video looks at the APLS approach to the management of a sick child.
Hello James, I'm Claire, I'm one of the doctors.
It just murmurs to you and moves a little.
On initial assessment, it is clear that the child is unwell. He mumbles only when spoken to. From this, you already know he has a reduced conscious level. It is therefore appropriate for ask for help straight away.
I'm already a bit concerned about this boy from his responsive level. Would you mind contacting paediatrics, please, for me, and the intensive care teams? Thanks very much. I'm just going to start off by looking at his airway.
It is important when assessing the airway to initially look, then listen for any added sounds, and inspect the airway.
Anything obvious in his airway to see at all?
No.
Any added sounds or funny noises from his airway?
No.
Okay. Could you put on some oxygen, please? 15 litres via non-rebreathe.
Always remember to apply high flow oxygen.
Just move on to breathing.
When assessing breathing, start with inspection of the chest. This should include looking for signs of work of breathing, such as sternal recession, subcostal recession and intercostal recession, as well as tracheal tug. Ask the examiner for the respiratory rate and oxygen saturations.
Just have a look at his chest. What's his respiratory rate?
His respiratory rate is about 40 breaths per minute.
Okay, could you put on a saturation probe, please? He's a little bit tachypneic.
Saturation is 94%.
Okay, so now a little bit on the low side because he's on oxygen as well. If I have a look at his chest, how does his breathing look?
It's symmetrical and equal and normal depth
Okay.
of breathing, but fast.
If we have a listen to his chest.
When auscultating the chest, remember to compare both sides and listen to the axilla. For palpation, again compare the sides and check the axilla. When assessing circulation, it is important to remember to insert an intravenous cannula. At this time, always state to the examiner what blood tests you would like.
We'll move on to circulation. Can you get access for me?
Sorry, yes.
Thank you. So I'd like to put in a cannula. We'll take some bloods while we're doing that. We'll take a venous gas, a glucose, full blood count, using these, CRP and some blood cultures. And while he's doing that, I'm just going to have a feel of my patient. How does he feel?
He's cold peripherally.
Okay.
Feeling for temperature can give you an idea of your patient's circulation. Cold peripheries suggest that they are shut down and vasoconstricted.
We'll do a capillary refill. 3, 4, 5.
It's over 4 seconds.
Okay, so it's quite delayed.
Central capillary refill should be less than 2 seconds.
Could you have a blood pressure, please, for him? And his heart rate.
It's at 150 beats per minute.
Okay. How is blood pressure read?
His blood pressure is a systolic of 70.
Okay.
Can't get a diastolic.
So he's tachycardic, he seems peripherally shut down, and he's a bit hypertensive for his age as well. Could we have a fluid bolus, please?
That's
So we'll do 20 mils per kilo. We're going on 16 kilos for him. The 320 mils of normal saline, just push through, please.
Fluid bolus in children is 20 ml per kilo of crystalloid, except in trauma, DKA or cardiac babies. In these cases, give 10 ml per kilo.
While that's going on, I'll just move on to D while he's doing that. If we use the AVPU scale, so he's obviously not alert, but does he respond to me talking? Hello?
No, there's no response.
And if I press my or squeeze a finger, does he respond to pain?
There's some groaning and he moves slightly.
We ain't quite concerned about. I've got ITU and paediatrics on the way.
When assessing disability, you can use the Glasgow Coma scale or the AVPU scale. For young children, AVPU can be easier and quickly done.
It sounds like he may well need intubating. And have a look at his pupils.
His pupils are on the small side, but they're equal and they
Okay.
react.
And is that glucose back from earlier?
3.2 millimoles per litre.
Okay, so again, that's a bit on the lower side. Could we have some glucose, please? So I have 2 mils per kilo with 32 mils of 10% dextrose, and again, just as a push. While that's going, we'll move on to E. So I've had a look at his chest already, but if I just strip him off and have a look at the rest of him.
When assessing E, ensure you fully expose your patient, particularly looking for rash,
And there's some petechiae around his ankles.
and take their temperature.
His temperature.
His temperature is 39 degrees.
Alright, so I'm concerned that this child, the cause for this is going to be meningitis or meningococcal septicemia. Could we have some antibiotics, please? So 80 milligrams per kilo of ceftriaxone, and again going on 16 kilos for him. We've done quite a few bits as we've been going along, so I'd like to go back again and reassess and see how he's done with those changes.
As per the Resuscitation Council's guideline, whenever you make a change in an APLS scenario, it is important to go back and reassess.
But I'm very worried about this child here. I think he's septic, probably from meningococcal, from his his rash, his temperature, and he's cardiovascularly unstable. I'd like him to get the paediatrician involved, get ITU involved, and I imagine he'll be intubated, have some inotropic support, and go to paediatric intensive care.
At the end of a scenario, always remember to tell the examiner your ongoing management plan.